Welcome to Psych Saturday, which is a series where we go over psychiatric disorders. Today we're going to be going over ADHD, also known as attention deficit hyperactivity disorder. And what we're going to go over today is very comprehensive. We're going to cover the differential diagnosis, meaning all the other diagnoses you have to think about when you're concerned about ADHD, the etiology, so why does this happen? How does this happen? The epidemiology, who does this happen in? What kind of population? The signs and symptoms. What are we seeing in people who have ADHD? The diagnostic criteria, DSM-5-TR, so how to diagnose ADHD. The treatment, namely which medications are prescribed for ADHD. And the prognosis, meaning how do patients with ADHD do long-term? So first, we're starting off with the differential diagnosis for ADHD. ADHD is a lifelong disorder. So when considering a diagnosis for ADHD, the pattern has to be lifelong for the patient. They have to have always had this, especially prior to the age of 12. Some other psychiatric diagnoses that can mimic ADHD include depression, mania, which is from bipolar disorder, anxiety disorders, substance use disorders, psychotic disorders, learning or intellectual disability, autism, child abuse, eye or ear problems, so not being able to hear or not being able to see correctly, sleep disorders, different types of seizures, maybe absence seizures, or conduct disorder or oppositional defiant disorder. Now, what's the etiology? How does ADHD happen? Well, predominantly, it's a disorder of having too little dopamine, also known as DA, and too little norepinephrine, also known as NE, in the prefrontal cortex, which is a part of the brain which is associated with attention, distractibility, concentration, and complex tasks. When we go a bit deeper into the etiology, there are two specific receptors on neurons in the prefrontal cortex, namely the D1 receptors and the A2 receptors that play a role in ADHD. When dopamine levels are normal, dopamine attaches to these D1 receptors and decreases the signal, therefore decreasing the noise, decreasing the amount of distractibility. So as we know in ADHD, there's a decreased amount of dopamine. So when we're looking at the D1 receptor, if there's not enough dopamine able to bind to the D1 receptor, then the noise will be high and distractibility will be high. When we're talking about A2 receptors or A1 receptors, those are both alpha receptors, and norepinephrine attaches to those. So a normal functioning brain will have enough norepinephrine, which will bind to the alpha 2 receptor, the A2 receptor, which will increase the signal through the neuron and therefore increase attention. So in a normal functioning brain where there's enough norepinephrine and enough dopamine, there's increased signal, which gives increased attention, and there's a decreased noise, so that means you can block out distractions. So the epidemiology, who does ADHD happen in? Well, first of all, there's a big genetic component to this. There's actually a 75% chance, so 3 out of 4, that your children will also have ADHD if you do. Now, since ADHD is primarily a childhood-aged disorder, although it can persist and we'll find out later has a 90% chance of persisting until adulthood, when we're looking at the epidemiology, how often does this happen? How often does ADHD happen in school-aged children? It appears to be in the 9 to 15% range of all school-aged children. And when we're talking about specifically the predominantly hyperactive type, it's a 4-to-1 ratio from boys to girls. So boys are 4 times more likely to have just that hyperactive one. And when it's just the inattentive type of ADHD, it's a 2-to-1 ratio from boys to girls. So boys are still more likely, but it's lower than just the hyperactive type. With the inattentive, they have a 2-to-1 ratio from boys to girls. Children with ADHD often find they have difficulty in school and they're starting to fall behind. And why this happens actually makes sense because in studies where brain scans of children with ADHD are done, comparing children without ADHD, The children with ADHD are actually 2 years behind in development of their prefrontal cortex, which is exactly what's needed to do well in school, planning ahead, concentrating, and distractibility. So what are the signs and symptoms of ADHD? Well, they're the same as the diagnostic criteria for ADHD, and we're going to get right to that. So here we go. The diagnostic criteria for ADHD. So how do you diagnose this? Well, there are two main categories for ADHD. There's the inattentive symptoms, which we have here, and there are the hyperactive symptoms, which we can see here. Let's go over the inattentive symptoms first. There are 9 inattentive symptoms, and to make a diagnosis for ADHD, the child needs to have at least 6 of these 9. And these include fails to pay attention to details, has difficulty sustaining attention, doesn't seem to listen, has trouble following through with tasks, has difficulty with organization, avoids tasks that require prolonged mental effort, loses important items, is easily distracted, and is often forgetful. Now, these are the hyperactive and impulsive symptoms, and these are often lumped together. And when you're making a diagnosis, these are all lumped together. I separated them here into the hyperactive type and the impulsive type for educational purposes. The inattentive type of ADHD and the hyperactive type of ADHD can both be separate diagnoses. If you have 6 out of the 9 of the inattentive, you can make a diagnosis of predominantly inattentive type of ADHD. And if you have 6 out of the 9 of the hyperactive symptoms, then you can make a diagnosis of predominantly hyperactive ADHD. Of course, if a patient has both criteria for inattentive and hyperactive, then they would be diagnosed with ADHD combined type. Let's go over the symptoms of hyperactivity and impulsivity. There are 5 hyperactive symptoms. The child fidgets or squirms often, can't stay seated in their seat, runs around a lot, is often on the go, has difficulty doing things quietly, talks too much, talks over others, has little patience and doesn't wait turns well, and is intrusive on others' activities. Again, you need at least 6 out of the 9 symptoms in either the inattentive type or the hyperactive type, or you could have both. Now, there is a caveat to that. If the patient is 17 years or older and you're making a diagnosis of ADHD, the new guidelines now say you actually only need 5 out of the 9 symptoms in either category to make this diagnosis. Again, these symptoms have to have had been present prior to age 12. When you're talking about these symptoms and asking the patient how they responded in the past and how things were in school. There's no specific amount of symptoms that have to have been present prior to age 12. However, the DSM-5 says several. So I wrote here 2 to 3, which seems accurate. Of course, these symptoms can't only take place in one environment. If the child has difficulty concentrating at school, but not in a different environment, namely not at home, then that wouldn't be diagnostic for ADHD. So what are the treatments for ADHD? Well, when we remember back to the etiology, how does this happen? ADHD is caused by decreased norepinephrine and dopamine in the prefrontal cortex. So most of these medications are going to increase either dopamine, norepinephrine, or just norepinephrine, or a little bit of all 3. There are 2 main types of ADHD medications. The first one are stimulants, and those include amphetamines and methylphenidates. There are only 2 prodrugs that we know of right now. One of them is for amphetamines, and that one's called Vyvanse, also known as lisdexamfetamine. Lisdexamfetamine has a lysine attached to it that when the Vyvanse is ingested, the body cuts off that lysine from the dexamphetamine molecule, and so it slowly releases in the body over time. The other one that's also a prodrug is called Astaris. Astaris is also a prodrug because it has dexmethylphenidate, which has a serine attached to the dexmethylphenidate. Going back to amphetamines, Adderall is a combination of dextroamphetamine and amphetamine mixed salts, and the rest are all methylphenidates. Focalin is dexmethylphenidate, Ritalin is just methylphenidate, and so is Concerta. These are all just different brand names. The other type of medications that are used to treat ADHD are called non-stimulants. The reason these are called non-stimulants is because they either don't increase dopamine or they don't increase dopamine much at all, very little. And that one is only bupropion. That one increases dopamine, but it's so small that it's not addictive. Bupropion is a norepinephrine and dopamine reuptake inhibitor. Both atomoxetine and Qelbree are norepinephrine reuptake inhibitors. There are two more ADHD medications which are not mentioned here, and those are clonidine and guanfacine, which are alpha-2 agonists, and they also increase norepinephrine in the prefrontal cortex. So what's the prognosis of ADHD, and how do these patients do long term? Well, as we mentioned earlier, 90% of children and teens still have ADHD as adults. This is changed from what we previously thought. This is new information. We used to think about 50% of children and teens went on as adults to have ADHD, but now we know it's a lot higher than that. Now, although most children and teens will go on to continue having ADHD as adults, oftentimes the hyperactive and the impulsive parts of ADHD, if the patient has a combined type, oftentimes those parts will go away in adulthood, but the inattentive part will stay. Adults with ADHD are actually more likely to have comorbidities as well, which means having other disorders along with the ADHD. And some of these include learning disorders, anxiety disorders, mood disorders, substance use disorders. Now, it is known that adults with ADHD have a lower life expectancy. It's not exactly known why that is, but it's theorized to be because of the increased impulsivity, which might cause the person to engage in risky behavior. The more comorbidities the person has with their ADHD, the higher their risk of passing away is. Here are some pretty alarming numbers that we're going to go over. When looking at this, there's the hazards ratio, which you need to know what that means in order for it to make sense. But basically all it means is the chance that something bad will happen. And I've put a more easily understood number right next to it, namely those percentages. So when you look at this, ADHD with one comorbidity, let's say ADHD with anxiety, the person is 321 times more likely than someone without ADHD to pass away. And these numbers really skyrocket with the more comorbidities the person has with their ADHD. ADHD with two comorbidities gives you a 757 times more likely to pass away. 3 comorbidities makes you have a 1,469% more likelihood of passing away. And 4 comorbidities gives you a 2,823% chance that it's more likely that you're going to pass away. Now, the good news is that oftentimes we can prevent certain psychiatric diagnoses from developing if the ADHD is treated appropriately and early enough. That's what this number needed to treat means. It means how many people do you have to treat to prevent a certain problem from happening. Now, if we look at the first one, it says NNT, number needed to treat of 3. So in ADHD, you need to only treat 3 patients for one of them to prevent one of them from developing either conduct disorder, anxiety disorder, oppositional defiant disorder, or repeating a grade, which is great. The number needed to treat of 4 means you have to treat 4 patients with ADHD to prevent one of them from getting a depression or having a car accident, which is excellent. Number needed to treat of 5 to prevent a bipolar disorder. Number needed to treat of 6, meaning you have to treat 6 patients with ADHD to prevent one of them from smoking cigarettes. Oftentimes, patients with ADHD will self-medicate by using over-the-counter stimulants like caffeine or nicotine, which is in cigarettes. And number needed to treat of 10, meaning you have to treat 10 people for ADHD to prevent one of them from developing a substance use disorder. If you're not familiar with the number needed to treat, here we're going to compare the number needed to treat of atorvastatin to prevent artery plaques from building up so you don't have a heart attack. The number needed to treat is 30 for atorvastatin if you're using a moderate intensity dose, meaning you have to treat 30 patients to prevent one from getting atherosclerosis, which is artery plaques. And the number needed to treat is only 20 for a high intensity atorvastatin, so a high dose atorvastatin to prevent artery plaques and atherosclerosis from developing in a person. So you need to treat 20 people for one of them not to get artery plaques and not to develop atherosclerosis. So that can put into perspective the number needed to treat for the ADHD and psychiatric disorders versus the number needed to treat here of atorvastatin and developing artery plaques. So what are the biggest takeaways? Well, ADHD is caused by a decreased amount of dopamine and norepinephrine in the prefrontal cortex of the brain. ADHD is very common in school-aged children, and it happens in about 9 to 15% of school-aged children. How do you treat ADHD? Well, you have to increase what's low. Dopamine and norepinephrine are low, so we give medications to either increase norepinephrine or we increase both, dopamine and norepinephrine. And a new statistic here is we found out that 90% of children and teens still have ADHD once they become adults. Let me know in the comments if you have any questions and what you'd like me to cover next.